So last time we were discussing stuff, we finished talking about the various arrhythmias. We looked at a couple ECGs, and there were a bunch of practice questions to check out. So always make sure that whenever you revise this stuff, you go through it all. And the pictures that I put here are always going to be significant. So there's one I wanted to look at before we get started for today's thing, which is what we see at the bottom over here. Right. So I didn't put the whole question here because what you'll notice eventually when you start doing more CK practice questions is that, especially on New World, is that a lot of the CK questions are extremely lengthy. So there's a lot happening in the questions, mainly because they want to deter you from being able to find the correct answer choice. They also want you to be able to pick and choose what are actually meaningful and significant symptoms that the patient might be having. Because when you start your actual practice, what you'll notice is that patients are going to come in telling you their life story. You know, a patient might have had just a simple issue like lightheadedness, but they'll start telling you about every single thing that's been happening in their life, even though a lot of those symptoms might not be related to lightheadedness at all. So you're going to have to figure that out and not get misled. So I didn't put the whole question, but I did put the ECG and then this image they had added for this question. So I wrote, to the left is the ECG results of a 24-year-old patient with occasional morning dizziness and palpitations over the past year. So if you ever get a question with a 24-year-old who's having dizziness and palpitations, that's really concerning, right? Because there's no reason whatsoever for a 24-year-old to have any of these issues, because it's very rare to see cardiac problems or blood pressure problems in general for a young person. Then they go on to tell you that so it's a female, she is otherwise asymptomatic. In the ECG, you can note sinus rhythm with borderline bradycardia and normal heart axis. So they gave you this ECG, which upon initial evaluation, when you first just look at it, it doesn't look so bad. It doesn't seem like anything's far off, and we're gonna delve into this. Then they go on to explain the ECG over here. So I wrote that there looks like there's borderline bradycardia, and the heart axis is fine because remember, for heart axis, you just look at 1, 2, and ABF, and all three of them are pointing up. They then broke down the fact that the first beat of lead 3 has aberrant conduction, leading to a broad QRS. Right. So in lead 3, you can see how this QRS complex over here. Let me grab my pencil. So this QRS complex over here is a little too stretched on that part right there. Okay. So you, generally speaking, you want it to go straight up and straight down like that. What you're seeing in lead 3 over here is something that it went up, but then coming back down, it had this like weird slope right there. Okay, so yes, I agree. It's going to be very hard to see that to the untrained eye. It might not even look like a problem. It might actually look normal. But now that I pointed it out, it should be a little more obvious. You can actually kind of see that here too. Right, so there. Remember, these lines are very sensitive. So every single thing that you see on an ECG is actually significant. It's not like something you can just brush over. So if it doesn't go straight up and straight down, that's not normal. Right? So if it goes up and has a curvature on either side, remember yesterday we looked at curvatures that can occur on the left side of an ECG, and remember that this part was called the delta wave, which was what you see in Wolff-Parkinson-White syndrome. So that's something that they pointed out. Then they wanted to know what you do, right? So the answer here was actually just to give reassurance. That's all there was. Reassurance was enough. Asymptomatic patients with atrial premature beats do not require treatment. It should be advised to avoid triggers like alcohol, caffeine, and stress. Now, some of the questions on step either 1 or CK, when the answer is just do nothing, that's usually the hardest answer choice to pick, because you start doubting yourself. You're thinking, is it really reassurance, or should I maybe order a certain test for this patient, maybe put them on a certain medication? And the ECG isn't the prettiest ECG, right? I mean, if you evaluate this the way we've been training ourselves, then you cut this in half over here, you look for the all-wave progression, and you can kind of see it, but it's still a very weird ECG, because what you're seeing is, yes, it should be pointing down in V1, and it does, but then there's this weird thing, right? And same thing again in V2, you can start seeing that there's a transition. Now it's pointing more up, and this portion is pointing down, and it's slowly gonna all become just pointing upwards by the time you get to V6, right? This is also pointing up, this is also mainly pointing up. So we see that, but then there's these weird things that are happening here, which we don't really expect, right? We don't want to see these, the ones that I've circled. So those definitely look slightly concerning. But keep in mind that R-wave progression and problems in R-wave progression are never really completely diagnostic of a specific pathology, right? It just means something's wrong. If you don't see your all-wave progression, then it means that everything isn't working perfectly and something is wrong. Now, what's wrong gets figured out by looking at things on the left side. And again, AVR should be the only guy pointing down, and he is. 2-3 AVF, when we evaluate them, we do see something weird, which is the curvature that we pointed out earlier. But there's no ST elevation, ST depression, none of that. So all this really was, when you finally look at this lead down here, you start seeing that there's somewhat of a extra beat every now and then, right? So this is very, very far. First of all, that should be immediately apparent, right? And that's what they're talking about with the what do they label it? No compensatory pause between premature blah blah. Atrial premature beats. Okay. So that's all she really had. But her morning dizziness is actually due to the fact that she also has some level of bradycardia, right? You can see how this is far too many boxes. It should really only be about 3, maybe 4 tops, but that's about it. This is about 5 boxes here. And we see another big one here. But then there's this little one here within 2 boxes. And then it goes back to a bunch and a bunch. Right? So there's some kind of weird premature beat thing happening here. And the reason this question was put here is because it's actually relevant to the various arrhythmias that we looked at yesterday. Right? So it's going to be one of those guys. But the other thing I wanted to point out was this image here. So this stuff is also going to be relevant for patients who have heart failure. Oftentimes you'll get questions where they'll mention that a patient has flat neck veins. Right? And we talked about that a little bit, that when you look at anyone, generally speaking, you're going to be able to see their neck veins. It's not going to be like it's not visible. And if that person is singing or yelling or shouting or maybe working out, then the neck veins become even more prominent. But if they're flat, then that's usually a sign of heart failure on the right side. So here they're talking about estimating central venous pressure by just looking at a person. Okay, so this is a person laying on about a 30 to 45 degree incline. Let me make the image bigger. Okay, so here you can see person is laying on a bed at about a 45 degree incline. They're showing you how you can see the sternal angle, and questions will give you this information. So they'll just toss the information at you, hoping that you know what to do with it. So on the left here, you're seeing what's normal, which is that the neck, the venous pressure coming from, which right here, which is your right atrium, should really only back up to about here, which is at the 3 centimeter point. Right, so from 3 to 1 centimeters, this range is okay. As soon as it goes over 3 centimeters, then you call that elevated jugular venous pressure, and that means that something's not okay on the right side, and blood pressure is actually backing up. So you can start thinking maybe there might be a tricuspid valve problem, maybe a pulmonic valve problem, or maybe the person just has too much fluid overload. So those are some things that we're going to see now in today's topic. We're diving into congestive heart failure. Now, congestive heart failure and most of everything else in cardiology here, cardiomyopathy, coronary artery disease, right, all these other topics over here, are all the same topics that were discussed in step 1. None of this is brand new. So it's really just figuring out what to do next that's new here. Okay, so there's not going to be much here that's going to be teaching you anything brand new. So everything was already talked about in step 1 first aid. So what I'm actually going to do is I'm going to go back to the step 1 first aid to look at this topic, and then come back here to look at the new things they mentioned regarding how to manage a patient. This is pretty nice because even with my step 1 class, we're actually on the topic of cardiology as well. So that works out pretty well. Okay, right here. So first aid step 1 has this one entire page dedicated to talking about heart failure, and they just have a little bit of a description of things that are related to left heart failure versus right heart failure, and then a bunch of new images. Like this thing was relatively new for first aid step 1. And then the next page is going to be stuff that I talked about for the various topics when we were all talking about step 1 things. But let's break into this really quickly with the notes I have up here. Okay, so first topic here was cardiomyopathies, and we'll come to this when we're talking about cardiomyopathies, but let's see what's happening here. So a person can have either systolic or diastolic function, right? Systolic function meaning that, or dysfunction. So systolic dysfunction meaning that you're unable to contract your heart. and diastolic dysfunction meaning that you're unable to actually fill your heart. Systolic dysfunction occurs due to multiple myocardial infarcts that decrease the number of myocytes, so decreasing left ventricular contractility. This drops the stroke volume, and the drop in stroke volume increases the residual volume in our chambers, which means that more heart ends up remaining inside the left ventricle since it cannot contract. This thus increases your end diastolic volume and drops the ejection fraction and cardiac output. So we use ejection fraction as a way to diagnose systolic heart failure. This backs up into the lungs, right? So blood, if blood is stuck in your left ventricle, then blood will be stuck in your left atrium. If blood is stuck in the left atrium, then blood from your lungs cannot enter the left atrium. So all of this backs up into your lungs, leading to pulmonary venous congestion and subjects the right ventricle to higher pressures, leading to a decrease in right ventricular output. That leads to peripheral edema due to backup of blood in systemic veins, which you're going to see as jugular venous distension. Coming back to why we started with that picture up here today, right? So you're going to see jugular venous distension in these people as well, and that jugular venous distension also often, is just related to your central venous pressure. Same exact thing as you can see here, right? So CVP, JVP is pretty much the same thing. Your central venous pressure is just your jugular venous pressure plus the depth to the right atrium, which is this measurement we're doing here, and so that's why these numbers are the way they are. Normal central venous pressure is 6 to 8. Right? Anything more than 8 is a problem. So you just think of 8 as the cutoff point for CVP. And you're gonna have that data in question. So always understand this, right? This one paragraph up here basically summarizes everything that goes wrong in left heart failure and then how that leads to right heart failure, because everything is just backing up. Now the diastolic heart failure is tricky. Diastolic is tricky because the problem isn't with volume. Ejection fraction and end diastolic volume will actually be normal with diastolic heart failure. So a person with diastolic heart failure and only diastolic heart failure will have normal ejection fraction. At that point, you might think that the heart is working fine, but it's not. Remember that ejection fraction is a fraction, which means it's a ratio. So if the numerator and denominator both change the same way, the ratio won't change. And that's what happens in diastolic dysfunction. The amount of blood you put into the heart became lower, right? And then that's why you also just pumped out lesser blood, thereby changing the numerator and denominator the same amount, so the fraction remained the same. In systolic dysfunction, you were putting a lot of blood into the heart, but you couldn't pump it out, so only the numerator changed. Systole became very, very low, and your ejection fraction was able to reflect that. So with diastolic dysfunction, ejection fraction is going to be normal. The problem is a decrease in compliance, right? Compliance is gone now. So this we talked about regarding the various curves we've been looking at with the step 1 class. So let me show you what we're talking about here. Because this is also stuff that can theoretically pop up on CK, because they obviously expect you to know this very, very well. So first aid step 1 doesn't talk about this curve very well, but this image here does a great job showing you the flow volume loop perfectly. And first aid shows you all the things regarding this yellow circle and how the various different changes can look like, right? So that your aortic stenosis curve looks something like that. If you have increased ejection fraction or increased contractility, then it goes further this way and stuff like that. So you've seen those are all in the book right here. That's fine. What they don't show you is these lines. The vertical, the slanted line you're seeing over here, which is for contractility or inotropy. And then this curved line you're seeing here, which is for compliance. All right, so every time you see this line move up like that, from normal to up, because the orange circle in here is the pathological person, the yellow circle in here is the normal person, and you're seeing a bunch of other examples over here, similar to how the book gives it to you. You can see that, and this blue circle is what we're actually exactly talking about, the blue outline over here. So what you can see is that if this line goes up, this is an indication that you have decreased compliance, okay? And in this Amboss image here with the blue loop, you can actually see that, right? The curve went up. This curve at the bottom is called the compliance curve. It went up. So if the curve goes up, that actually shows decreased compliance. You lost the ability to have compliance, which means that as you're filling the ventricle, it won't expand, okay? This other curve, what you're seeing right here, this thing is, the slope of that line actually shows you how good your contractility is. So as that slope falls down, is directly related to having a lower contractility. All right, so that's what you see with the yellow curvature here. Right, so this graph here is actually perfect for the topic we're talking about today. Right, where you can see your blue loop, you have reduced volumes because you're not able to fill. Right, compare the blue loop to the green one. So it was initially filling all the way up to 100 milliliters, but now it's filling less than that. Your stroke volume was this big before. Now you're gonna have about the same kind of a stroke volume for the most part, right? Because look, both things shifted. This shifted this way, this shifted this way. The difference between the two arrows I made pointing towards the left isn't that vast. So your ejection fraction ratio actually ends up staying the same. And the biggest thing about this is that your compliance curve went up, so your compliance has actually decreased. If we were to draw our contractility curve, that doesn't change. You can see how the blue loop and the green loop have about the same contractility. Right? That's because contractility is working. This is mostly just a systolic, diastolic dysfunction where you're unable to fill. Compare that to the systolic dysfunction. In the systolic dysfunction, the compliance curve is perfectly on the dot with the yellow curve, just like the green curve. So compliance is not changed with systolic dysfunction. What is changed is that there's a drastic drop in what was the normal contractility to what's here now. Right, so that's a very big drop in the slope of the contractility. This would be the normal one, and then if I move it all the way to here, this would be your pathological one. Right, so that's not okay. So these curves can be given to you on CK as well. There's no reason for it to not be given to you on CK, and you have to make sure you understand that. Because if you can't read that curve, you're going to have trouble actually diagnosing what the problem is. Oftentimes, if the question gives you any of these graphs, they don't need to tell you anything else because the graph tells you the whole story by itself. Now, at the bottom here, I wrote both lead to full-on heart failure, whether you have diastolic dysfunction or systolic. Right? The diastolic was only on the right side, though. Let's finish reading this. So the problem is the decrease in compliance, meaning the left ventricle is stiff. So we need more pressure to fill in diastole. Increased left atrial pressure will lead to pulmonary venous congestion because all that pressure is going to back up into your pulmonary veins, into your lungs, and then come back around to the right side again. This is going to increase afterload for the right ventricle and lead to systemic venous congestion. So now it's the whole body once again. You're going to have elevated JVD and peripheral edema, all the same consequences. Diastolic dysfunction leads to decreased contractility and cardiac output, even though ejection fraction and end-diastolic volume are the same, because the hypertrophic myocardium is susceptible to ischemia, leading to infarcts that cause left ventricular dysfunction. This brings us back to the topic of S4. Right? Remember that all the sounds are in order, so S1, S2, S3, S4. S3 and S4 occur in diastole, and S4 obviously occurs in late diastole, which is when you're just about finished putting blood into the ventricle. The only time S4 actually occurs is in pathological cases where your ventricle is not compliant. Right? So you're going to hear S4 in these people for sure. Both lead to full-on heart failure, and you're going to have a bunch of compensatory mechanisms, which is what you're seeing in this diagram here, that you need to master and comfortably understand, because this is where you're going to get questions. And the things you're seeing in this diagram are your potential answer choices. Like you can have a question where the correct answer is more sympathetic nervous system activation, or more renin-angiotensin system activation, more ADA secretion. These are all things that you can have as answer choices that you've probably already seen if you've been doing these practice questions. So let's take a look at this pathogenesis diagram here. And this link from Osmosis, by the way, did a great job explaining it as well. So if you want to check that out, feel free to. So first thing you see, decreased cardiac output, right? Because of course your heart is failing. So this decreased cardiac output means that less blood is getting to all the different parts of your body. So the first part of your body that you really want to think about when you think of blood is not really getting there is your brain. If you fail at sending blood to your brain, you're pretty much about to die, right? So if you're ever undergoing some kind of case scenario where you're about to die, you will immediately have sympathetic nervous system activation. So that's pretty commonsensical and pretty easy to think of. The only reason it's not really common sense is because the average human who hasn't gone to med school wouldn't give you this answer choice, right? So it's not really common sense, but when you talk about it and you break it down, and at this point, it's supposed to become common sense for us. So it makes sense, right? And you can think of this. So of course, if you're about to die, your heart rate is going to go up and you're going to try to increase contractility. Okay, that makes sense. You're also going to have more renin-angiotensin system activation. Remember that renin-angiotensin and angiotensin in general is something that's going to help you vasoconstrict. The point of vasoconstriction is always to stop keeping blood in the blood vessel and squeeze that blood vessel to send blood to the target organ, which in our example is the brain. So you're going to increase your blood pressure to send blood to the various different organs that are not really getting enough blood due to the decreased cardiac output. Last thing here is antidiuretic hormone secretion. This has one purpose only, which is antidiuresis, so you stop peeing. This is going to increase your extracellular volume, which will further help you do the one thing they're all trying to do, which is maintain blood pressure. Okay. However, in this mechanism, right, in this mechanism where your heart is trying to survive and trying to make it through and pretty much live, it actually ends up causing more deleterious cardiac remodeling. So in efforts of saving itself, the heart actually ends up putting more stress on itself, and then this is pretty much a progressive issue that if not dealt with, the person will die, right? So that's what we're seeing here. So you have your long-term neurohormonal activation, which leads to increased hemodynamic stress, and the two guys together lead to more remodeling that isn't good. Right, so this is all your congestive heart failure. Now, when you're actually taking your test, you're going to see two types of congestive heart failure. There's going to be the decompensated type, and then you're going to have compensated. So when it's decompensated, that actually sounds like something bad, right? So that means that these processes are still happening, right? It's decompensated. These processes that we're seeing in this diagram for the pathogenesis are actually all compensatory mechanisms. So if they're not completed yet, then it's still decompensated heart failure, which is still trying to recover and trying to remodel things. And it's a progressive issue, right? So what you're seeing in these x-rays here that you're definitely going to have in your CK, decompensated heart failure chest x-rays show bilateral airspace opacities, right? Opacities are what you see, for example, all over the place. It's not nice and clear. Okay, that's what you're basically seeing. And the fact that there's extra haziness in this area, as you can see, right? All this extra haziness that's like not going to be there in the normal x-ray. Right? You can see in both of these people, there's a bunch of haziness everywhere. It's supposed to be nice and clean. Always have a good understanding of what a normal chest x-ray is supposed to look like so that you're able to compare, right? And then these haziness areas that Amboss is highlighted in blue are signs of heart failure. This is not okay. Right? So as soon as you see all this haziness in the chest x-ray, you should start thinking of heart failure and start figuring out reasons a person might be having heart failure. So when I was teaching for step 1, I had all these extra x-rays around here to be able to compare all the different kinds of scenarios a person can go under. It's really helpful stuff. So, of course, if you haven't practiced looking at something like x-rays or microbiology slides, like the histo slides as well, you're not going to know what you're looking at. Right? So you want to make sure you practice looking at a variety of x-rays so you can actually figure out the differences between them, right? The more you practice looking at these things, it's like a photography session. You want to have the eye to know what you're looking for. And then again, further on, the most important thing you're always going to see in most of these x-rays is the costophrenic angle is no longer visible. You see this angle that's supposed to be there? You can't really see it because it's full of stuff, right? So blunting of the costophrenic angles due to pleural effusions, which is usually an inflammatory process. The fissure sign created by fluid trapped between the lobes, which you can't really see in my image because it's too small here, but in this Amboss image, you can see all the signs. Right? They highlighted it very nicely. This is the highlighted version, this is the clearer version, so you have all of that for comparison purposes. And again, to the untrained eye, these yellow lines that they're making here, these white lines that they're making here, you don't see any of that shit. Right? It doesn't really show up to us. We can't see it. Took me a long time to start catching that on my own in questions where, before I would do this, I would try to find it myself, and it took a very long time to start finding it, right? Because it's just something you have to train yourself for. Okay, so again, these compensatory mechanisms all have to be met for it to be then considered compensated heart failure, and that's what I'm explaining down here. So compensated heart failure means your heart works well enough that you either don't notice any problems or the symptoms are manageable. You don't have the fluid buildup in your legs and feet, and you can breathe without trouble. Your body still seems to be doing okay, even with the changes in your heart's pumping ability. Decompensated heart failure describes obvious symptoms that affect your overall health and quality of life. For example, congestion in your lungs that makes it harder to breathe, so you wheeze or cough. You may have abnormal heart rhythms like arrhythmias, and all those are things that can lead to death. This question down here then went on to explain why, it's significant to be able to identify the two different types of things, two different types of heart failures. And here you can see this is an answer choice from the list of things we were looking at. Increased sympathetic nervous system activity. Literally one of the things that's in the diagram. Right? So this is just where you get all your answer choices from, basically. And the flow volume loop that we just looked at is right here, where they're now starting to show you in first aid the compliance curvature as well as the contractility line, because those are the only ways you can really figure out what's happening if nothing else besides this image is given to you. Okay, so now if we come back to here, it's all going to be the same stuff, nothing brand new here except for how to manage it and this CHAD score. Right, so let's take a look at this table here. Make it big. And they have it in the book as well. They try to break it down for you. So in the book they tell you use the CHADS VAC score system to estimate the stroke risk in atrial fibrillation and anticoagulate with NOACs, which are your non-vitamin K antagonist anticoagulants. Okay, very important ones to know. Non-vitamin K antagonist anticoagulants like dabigatran, rivaroxaban, apixaban, and edoxaban. All these bands and the dabigatran. Or you could use warfarin, which is used with mitral valves or mitral stenosis. For anyone who has a score that's significant enough, right? And we talked about this scoring system and how you're supposed to get only 9 points and not 10, because you don't really add more points for these scenarios together. You either add 2 or you add 1. So you would get a maximum of 9 points. Okay, you don't add both of them. That's not how that works. So if someone is over age 75, you would add 2 points. That's it. If they're under 75, you would only add 1 point to the scoring system. Now, you're not expected to really remember this scoring system. You don't have to know this by heart, per se. And the more you practice medicine, if you become a cardiologist or anything, you will know it by heart. But the point here is to see all the symptoms you're supposed to be looking for. Okay, to then be able to figure out if there's a risk of stroke. Okay, because you don't want a patient to have stroke. So if you really think that there is a risk of stroke, you immediately start anticoagulating them to prevent that stroke from occurring. So if you have a patient who has congestive heart failure right now, they have hypertension, they are, let's say they're not over 75, maybe they are between 65 to 74. Actually, you know what, let's just go with someone that's 50. So we would not add this or add this, okay? And yeah, right, diabetes is going to be there. Almost every patient you'll ever have is going to have diabetes. And then maybe it's a female patient. Then already you can see enough points have been added up for you to start thinking there's a pretty potential risk of stroke here. And you now have to treat this patient to prevent that stroke from occurring. Right, so you're going to go ahead and anticoagulate the patient, give them anything else they might need if there's a risk of atrial fibrillation. Maybe they have a history of congestive heart failure and they've been in here before for the heart failure symptoms that they're getting right now. All of these are scenarios that are problematic, and you have to deal with it as soon as you can. Now, the reason this thing is important, the NOAC, NOACs, you don't really want to use the same kind of... So last time we were talking, we talked about the fact that there's a bunch of different anticoagulants out there, and you're going to get questions where you're going to have multiple anticoagulants as answer choices, all of which might actually look like viable anticoagulants. NOACs are special though. These are non-vitamin K antagonist anticoagulants, which is perfect for someone who might have low vitamin K. They significantly reduce systemic embolization risk with similar efficacy as warfarin, minus the severe bleeding risk or INR testing. Because remember, if you have a vitamin K antagonist, well, vitamin K is very important to stop severe bleeding. And warfarin in general has too many side effects. In fact, even using warfarin requires a heparin bridge, which again, you don't have time for that right now because you have to prevent this person from getting a stroke. Aspirin and clopidogrel therapy is much less effective here, right? This is something you send a person home with after you've dealt with all the problems they have. Right? Then they can go take aspirin forever at home and have clopidogrel and they'll be okay, hopefully. So make sure you go back and revise all your different anticoagulants and how they're different, what the side effects are, who can take them, who cannot take them, and so on. Another new thing you're going to see here is these weird names they have for the gallops, right? So again, systolic dysfunction versus diastolic dysfunction, and these loops and everything we just talked about is all here. There's nothing new here except this, okay? These things are pretty new. So what I did in your book, I put the link here for the Kentucky and the Tennessee heart sounds. These are perfect. I would recommend playing the heart sound at 0.5 speed to listen to it in slower speed, so you can actually admire what you're looking for. Because remember, heart sounds occur within a second, right? You get your lub dub and that's it. It's so quick that, especially to the untrained ear, it's very quick, and it's so quick that you can't really appreciate the sound you're looking for. So both of these are supposed to be heart sounds that occur in diastole. When a person has systolic dysfunction, there's already too much blood in your left ventricle. So as soon as you start diastole, there's going to be a new heart sound because you're basically smashing blood into a ventricle that didn't even get to empty yet. Okay, so you hear your S3. And apparently this heart sound sounds like saying the word Kentucky. That's what you're going to hear. Kentucky is the heart sound you're going to hear when you combine hearing everything you're supposed to hear, S1, S2, S3. For the person who has diastolic heart failure, right, this is considered heart failure with a preserved ejection fraction. That's what this means. So if it says HFpEF, this is heart failure with preserved ejection fraction. This one is heart failure with reduced ejection fraction. These things are synonymous to saying systolic versus diastolic. Right? So it's just fancy terminology, if anything. In these people with the diastolic dysfunction, you're going to hear an S4 gallop, which sounds like Tennessee. So listen to these heart sounds. Start admiring what you're supposed to hear. Also try so when you're listening to the Kentucky one, say Tennessee, and you'll notice it doesn't sound the same. Okay, so try it. Imagine that you didn't know. So blindly listening to heart sounds is very important. Okay, so listen to heart sounds that you don't know, and then try to see if you can hear what you're supposed to hear. Or if you have a study partner, tell them to play one of these two heart sounds, and you're supposed to figure out which one it is. And so that kind of manner of studying will help you be able to identify the heart sound on your test. Other than that, nothing else here is brand new. So they mentioned a bunch of things here that are all coming from step 1, and then I put the CK practice questions here for you so you can understand what you're supposed to know. Again, all these things are coming from the answer choices I was listing out right here. Right, so basically everything in this diagram are your answer choices, right? Both of these diagrams. These are different answer choices. So you can already see here, like constriction of renal efferent arterioles is something that comes from those answer choices, right? Basic constriction. In this diagram, again, they're showing you the chest x-ray with evidence of congestive heart failure. You have all this opacities and whatnot, and they've done a pretty decent job showing it to you. And in this table from CKU World, very important, right? Clinical features of acute decompensated heart failure, which we just talked about. The fact that it's not done going through all the compensatory mechanisms you need to. So then you have to treat this a little differently, actually significantly differently, compared to someone who's already got the compensation done. So this comes back to the topic of knowing all of your medications for step 1, right? So again, if you notice, if you go through first aid CK, they don't really have a pharmacology section like they did for step 1 first aid. So if you ever come to treatment things that you forgot, like if you forgot you loop diuretics, they were nice enough to write most of them out here and tell you the basic side effects, but they don't go into more detail because all of that is already there in your first aid step 1. So definitely make sure you go back and check anything you might not know. As you can see here, this is an overlap of cardiovascular with renal. Right, so these are loop diuretics and other diuretics that are all things that work on the kidney. But everything that happens to your heart, we already saw, is related to the renin-angiotensin system, and then of course things backing up into the lung. So respiratory and renal function are both heavily affected in a person with heart failure. Because you need, when your heart starts failing, it tries to call out to your kidney to get help, and that actually leads to bad remodeling. And when the heart starts failing, everything that your lung is trying to do becomes useless. So your lung starts failing too. And that's the stuff we want to avoid in these patients. So you can see here now treatment. So before ever really going into treatment, because treatment was step 1 stuff, knowing what treatment you have to give to these people is step 1 stuff. The more important thing here is finding the diagnosis. So this is what you get questions on. Patients are going to come in, and then your CK is going to ask you what's the next best step in management. So here they tell you diagnostic studies that may support the diagnosis include an echo. The best initial test is just to do an echo. Okay. ECG was the best initial test to do for anyone who had an arrhythmia, which was the previous topic we talked about. Any patient comes in with any kind of arrhythmia, palpitation, you do an ECG, you try to see if there's something wrong with how the heart is beating. But if a person has heart failure, it's nice to be able to do a transthoracic echo. Do not fall for picking the answer choice that says transabdominal echo, because if this is a long test. If you're in your 5th hour of the test and you're doing the 21st question of your 5th block, you're pretty worn out. And if you see transabdominal echo, you might want to pick that as an answer choice because you see the echo and you see the patient who has a heart failure, but then you just fell for a silly issue, right? Because transabdominal looks at things in your abdomen, which are your intestines, so that's pretty pointless for a person with heart failure. Transthoracic echo, right? You want to see a decreased ejection fraction, maybe ventricular dilation, any of these things, and then you would understand that the patient is having heart failure. A chest x-ray can also help, of course, because you're going to see all of these issues, and you'll also be able to rule out the fact that there's nothing else, like it's not like the person has pneumonia or some kind of lung cancer, none of that, right? You're going to see exactly stuff like this, and then you're going to know that this person is still compensating, so they're going to be decompensated for the moment to adjust to their heart failure. And of course, all your lab abnormalities, right? ANP, BNP, you can look for those natriuretic peptides that your heart actually has. It makes sense to have these there because this is actually what's going to add to the aldosterone escape mechanism. So if you don't know the aldosterone escape mechanism, which is related to things like Conn syndrome and hyperaldosteronism, definitely want to make sure you go check that out. But the general concept here is that this is natriuretic. So in the word itself, you can see Na for sodium and then uretic. So you actually urinate a lot of sodium, which basically prevents edema from forming. But it fails, right? Your heart is going to be doing a bunch of things to keep normal, but it's not all going to work. You're going to have low sodium in later stages for that exact reason, because you peed it all out. So it's all the stuff you can order, and overall, they tell you right here that CHF is a clinical syndrome whose diagnosis is mainly based off of signs and symptoms. Right? So that's like the first thing. As soon as you see a person presenting in a certain manner, not only do you realize what could be going wrong, but you often also realize things that are definitely not the main problem here. Okay, so always be quick to assess that too. And then I like this question. So I haven't done this much for most questions, but this question was really important to do this for because it was still in the early chapters. I wanted you guys to see what happens in this. So this is a pretty big question here. But then you see the part that I've underlined. That's basically the part that I felt was completely useless garbage in the question, that if you completely deleted that from the question, you would still easily, if not more easily, pick the correct answer choice. So let's take a look at this. It says a 65-year-old man comes to the physician because of a 10-day history of episodic retrosternal pain, shortness of breath, and palpitations. So that clinical scenario in itself is already telling me there's something wrong with the heart. Right? I'm not going to diagnose this person or start thinking that this person might have some kind of lung problem or a foot problem or anything stupid like that, right? It's really clear there's something wrong with the heart. Or at least one of my top 3 diagnoses for this person already is something wrong with the heart. The episodes occur when he climbs stairs or tries to walk briskly on his treadmill. So basically what he's having is retrosternal pain, which is chest pain, with activity, right? So remember, when I'm stopping to say these things, these are things that are happening in my mind very, very quickly while I'm reading the statement. Not that I'm stopping to think like this. Okay, so after I read these first 2 statements, in my mind, I've already assessed the fact that he has pain with activity. The symptoms then resolve when he stops walking. So then you know immediately that that's called stable angina. As soon as you stop an activity and now the chest pain goes away, that's stable angina. Great. Now listen to this useless part. The previous evening, he felt dizzy and weak during such an episode. He also reports that he had a cold 2 weeks ago. He was diagnosed with type 2 diabetes mellitus 4 years ago, but it is otherwise healthy. His only medication is glyburide, and he appears well. Okay, so all of this stuff, if anything could even possibly remotely be significant, is the fact that he had a cold 2 weeks ago, because that could be related to Coxsackie, which can then cause dilated cardiomyopathy, right? So that's about it. His pulse is 62 and weak, respirations are 20 per minute, blood pressure is 134/90. So you see how I didn't underline this as something useless, because these are his vitals. We need to know that. So what I'm seeing is that his heart rate is almost 60 now, so it's coming to the lower end of normal. And also, this is a person I will not pick a beta blocker as an answer choice. I'm not going to give him a beta blocker because I'll further lower his heart rate, and then he's going to have even more dizziness. Cardiovascular exam shows a late systolic ejection murmur that is best heard in the second right intercostal space. The lungs are cleared auscultation. What mechanism is the most likely cause of his current condition? So, again, in fact, we didn't need any of this stuff. We didn't need any of this. Right? We didn't need any of this. If we just read this first few sentences and we realize the fact that he has chest pain when he's doing activity, and then the chest pain goes away when he stops the activity, that is stable angina, and that's due to increased left ventricular oxygen demand. Done. So you see how they added so much extra junk to the question to really throw you off, make you think of many other diagnoses, definitely tire you out mentally, or especially if you're a bad reader and you read a sentence and then you had to reread it because you didn't catch it, or you read a sentence twice by mistake. Like, these are just dumb things that can happen, right? Mechanically, you can't do anything about it, and that just worsens stuff. All right. So this was an easy question. This is a very easy question, but they made it worse by adding all this gibberish. So train yourself to catch what's important in the question. Right? Very, very necessary for this test. You got to be able to do that, because you're going to have about over 200 questions, of course. So you don't want to fall into that. You can see already every question is a huge paragraph. Every question. And then they go on to talk about all the things you're going to have to tell the patient to do after they're done. Right? So with most heart problems, it's a huge issue to understand the fact that coming in for your heart attack was the easy part. Even getting the heart attack was the easy part, because you got a heart attack, sure. You had some stress and you fell and you had whatever problems, okay. But you didn't have to actually do anything for it. You felt some pain, all right. Then you got into the hospital. You were taken care of. That was easy. You got some stents placed. Again, also pretty easy. The hardest part is that lifestyle management stuff after being released from the hospital. Right? Like, if a person has had a heart attack and you send them home and you give them this packet of things to do, don't eat like this, make sure you work out like this, make sure you walk at least X, Y, and Z amounts, cut back on the salty foods, etc., etc. There's no way for you as a doctor to actually make sure they maintain that lifestyle. Right? There's no way. You can't force a person to change their lifestyle. And one of the worst things that we do as doctors in today's time is that instead of actually breaking down what to do, we just tell the patient, hey, you should work out more and you should eat less. Or, hey, cut back on X, Y, and Z foods and just work out more. Saying things like that is so vague that the patient is just going to hear you out and then walk away. They'll say okay and they'll just go home, continuing on with their life as if you never said a word. So one of the things that we need to get better at is how to explain this to a patient, right? You have to tell them exactly what to do. Like, literally break it down for them. So first figure out what they actually do, what they can do, right? And then tell them, like, hey man, if you could just take a walk around your block, like, once a day, that's a lot more than nothing. So let's start there, right? And then you get them started on that. Once a day, they're going to get out of their room, walk around the block, come back home. That's a starting point. It's better than not doing that, right? You have to make sure you break it down like that for them. It might feel like a lot, but at that point, if you can't do that, then just telling them you need to work out more is pretty useless too. So might as well not do that either, right? So very important to be able to do that. Very important to have cultural understanding of what kind of foods people do eat in different cultures. So, of course, you're not going to know every single culture and what they eat, but whatever you can know, or if you can do a quick Google of, what they eat. For example, if you have a patient from Ethiopia, you might not have any idea what their food looks like. So you do a quick Google of Ethiopian diets, see it, and then you tell them, hey, don't eat that, don't eat this. Cut back on this, eat fewer of this. Tell them to train themselves, right? Like, they can pick a day of the week. Once a week, that's going to be the day they're going to eat that one special food they like. That's it, right? Rather than quote-unquote snacking on it every day. These are things that are going to be very important because you want to prevent a patient who had heart failure from coming back for another episode of heart failure. Because that second time they get that MI, they'll probably die. And that's also something you could tell the patient. They need to know that. Other than that, some of these medications here, like ivermectin, sacubitril, ibuprofen, There's this dobutamine. These are all medications you want to make sure you know because they're actually very heavily used in the clinical setting. Like they're actually used, and CK is a test that's just like your actual clinical practice. So it's worth knowing them. Know how they work. Know why you give it to a certain person. Understand that not all these medications are actually covered by insurance companies. So oftentimes you might have a question where you have a person that's uninsured, so you're going to have to figure out a better answer choice for them. You don't need to know what is covered and what isn't covered, but generally speaking, it's pretty safe to remember that if a medication seems super fancy, like naproxen, or remember the new PCSK9 inhibitors that came out that work very similar to statins, those fancy medications are not covered by insurance companies, nor are any medication that are related to aesthetic things. Right, so medications that are for maybe for like acne, for example. So some acne medications are not covered at all because that's actually considered an aesthetic thing, and having acne is not a fatal problem, so it's not covered by insurance. So you have to pay for those. Okay, so that's basically all for that stuff. Same thing here, nothing brand new. Right, this is actually how the diagram looks like for CK. So now if you look at this one, right, eccentric left ventricular enlargement and heart failure. So this is going to now go into cardiomyopathy, which is the next topic. So you get systolic dysfunction. Okay, so this is considered the HF with reduced ejection fraction. Systolic dysfunction, this is going to lead to ischemia, possibly cardiomyopathy, where your heart is going to try to become stronger. That's going to lead to left ventricular volume overload, which obviously makes sense, right? Because if you cannot do systole, blood is going to remain in the left ventricle. Too much blood is staying in the left ventricle. Similarly, there's two case scenarios here. So this is case scenario 1. Similarly, you could also have scenario of these guys, aortic regurgitation or mitral regurgitation, which are going to be valvular dysfunctions that cause blood to regurgitate or come back to the left heart. Okay, so that also leads to left ventricular volume overload. Aortic regurgitation causes blood to come back from the aorta into the left ventricle. Mitral regurgitation causes blood to go from the left ventricle into the left atrium, which is backwards, because it's easier to go that way than to go into the aorta, which has really high pressures. Both of these kind of case scenarios lead to left ventricular volume overload. If your left ventricle is always full of blood, then naturally the Frank-Starling mechanisms kick in, and your left ventricle will stretch. And that makes sense. If you have a balloon that has too much water in it, you add more water to it, it'll stretch out. This initially will be maintaining cardiac output at first. The stretched left ventricle, that will obviously be thinner walled, right? So remember that your left ventricle has a bunch of muscle strands like that. If you're going to stretch this out, then it's going to become thinner, right? Where you're going to stretch it all out like that so that you have much more width covered, but now it's super thin compared to the original. So this is your eccentric left ventricular enlargement. So initially this will maintain cardiac output, but then when this becomes the new normal, cases 1 and 2 are going to start overloading that new normal. Remember, because heart failure is progressive, right? So this is going to keep getting worse and worse. So although your heart did something to maintain things and stay under normal function, this new normal will now be attacked. And then you're going to have to try again, stretch out more, but there's a limit to how much you can stretch, as you can see in this image. Right? There's overlap here and overlap here. You can't stretch out indefinitely. Similarly with the balloon example I gave, right? If you keep adding more water to that balloon, it'll just pop. So chronic volume overload leads to eccentric hypertrophy. Increased stroke volume is maintained at the expense of increased wall stress, right? The wall was very comfortable when it looked like this. Okay, but when it got completely stretched out and everything's at, end to end, this is literally very similar to saying meeting ends meet, right? Or living by the skin of the teeth. Right? This is not going to be good enough. So that's very stressful. So that's your increased wall stress. Overall, this increased wall stress will then lead to left ventricular enlargement and contractile dysfunction. Your ventricle is stretched out so much that now it's actually only good to hold the excess volume, but it cannot contract anymore. So you see the problem, right? This is going to then lead to decompensated heart failure. And this is where you have the symptoms. Everything becomes symptomatic. If a person is symptomatic, they're going to require treatment immediately, and you have to deal with this person very differently compared to this person here, who you can diagnose with heart failure because you would do the echo and you would see that the heart looks bigger, but they're going to be asymptomatic because, again, remember, they're maintaining things by creating new normals. Creating new normals is not the solution, though, because that's just making things worse for these patients. So now let's look at this topic of cardiomyopathy. So cardiomyopathy in step 1 was actually a very difficult topic, right? It was also very hard, high yield, and you had your dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, and it doesn't stop here. Most students, when they were new for step 1, they thought this is all that existed, but there's more, right? Then you have your other causes of left ventricular hypertrophy. This is different. Left ventricular hypertrophy is different from hypertrophic obstructive cardiomyopathy. So for your exam purposes, always remember that HOCM with the obstructive is its own little thing. HOCM is this autosomal dominant disorder with issues with the sarcomeric proteins and young athletes dying as soon as they try being athletic. Right? That's the problem you see in this case scenario. And then you have just HCM without the O. So if you just have hypertrophic cardiomyopathy, that could be due to chronic hypertension, where your left ventricle is becoming stronger in efforts of beating against a very high afterload in the aorta. Or you could have a person with Friedreich ataxia, which also causes left ventricular hypertrophy. In fact, one of the top reasons patients with Friedreich ataxia die is because of heart failure. Right? So this is actually notoriously seen in this wonderful question right here. So in this 54-year-old man over here, this person comes in due to severe shortness of breath and palpitations. So as soon as you hear that in the emergency department, you're thinking something's wrong with the heart. Right? That's all this could really be. Your top 3 diagnoses is going to include checking the heart. During initial assessment, pulse oximetry is 83%. You note diffuse bilateral crackles on lung auscultation. And then, of course, you order a chest x-ray. So remember, when you were doing step 1 questions, this was actually teaching you for step 2 CK, because if you read this question in this manner and you see they ordered a chest x-ray, then on CK you realize, that in CK, what do they ask you? What is the next best step? And the answer would be order a chest x-ray. So very important to understand that when you were doing step 1 questions, if you recall what you saw in step 1 questions, they were actually teaching you what to do for CK. So they ordered a chest x-ray and they noticed pulmonary edema. Then they did an ECG, which showed atrial fibrillation with rapid ventricular response. Okay. So this person was doing really bad in this case scenario, and he actually ended up dying. It says he dies despite appropriate medical care. Autopsy is performed, and a gross exam of the heart is shown in this picture. And of course, as soon as you see this picture, you're excited to pick hypertrophic cardiomyopathy. But look at the answer choices. There were 2 answer choices to pick from. Well, there's more to the question. So they finally said histologic exam of the myocardial tissue reveals thick myocardial fibers, which is pretty obvious here. What is the most likely diagnosis? So look, 45% of people pick the correct answer. Hypertensive heart disease. 35% of people, though, fell for hypertrophic cardiomyopathy. Right? And having both answer choices here is something that UWorld would do to teach you, because it's here to teach you, that this is definitely the better answer to pick. Okay, he does have hypertrophic cardiomyopathy. It's true. This is clearly hypertrophic cardiomyopathy. And this would be the completely wrong answer choice if it said hypertrophic obstructive cardiomyopathy, but it didn't. It actually put hypertrophic cardiomyopathy. So it's actually very safe to say that that is a valid answer choice. But remember that with STEP and with almost any multiple choice test you ever take, the concept is to pick the best answer. Even if 2 answer choices are correct, one will always be a better answer choice based off of probability or chances of how real it is and stuff like that. So hypertensive heart disease is correct because it's actually his hypertension that was probably untreated. He most likely was not treating his hypertension. Most people that have hypertension don't even know they have it because blood pressure is a silent killer. And then it came to a point where his heart actually tried becoming really brolic, as you can clearly see, leading to a smaller left ventricle, and now he has heart failure. Right? And this is hypertensive disease that led to hypertrophic cardiomyopathy. So both were correct answer choices, but you had to pick the better answer choice, and that's always going to be something that you have to practice. The other thing about heart failure in general was understanding the difference between eccentric versus concentric. Okay, so our guy in the question that we were just looking at, and every time you see this, you want to think of having circles that you're just adding more circles to, like the rings on a tree, right? You're just adding more and more circles into it until you became very constricted, and you have a very, very tiny lumen now in the middle, right? This is concentric. This is adding more and more circles to become more muscular and get hypertrophic obstructive cardiomyopathy, or hypertrophic cardiomyopathy due to chronic hypertension or any of these other issues. When you look at the other one, that's the one we just saw in CK in this diagram here, eccentric left ventricular enlargement. That's the balloon case, right? This is the case scenario where you're stretching out your sarcomeres to allow more blood to actually fit into here. Right, so this is where your ventricle, you can see how thin this is. This has become so thin. Here it became super, super thick, but now it's become super thin in this case scenario of dilated cardiomyopathy. Dilated cardiomyopathy and hypertrophic cardiomyopathy are both equally as high yield, but you are more likely to see dilated cardiomyopathy questions simply because there are more things that actually cause it, right? Alcohol, wet beriberi, Coxsackie, viral myocarditis, people that have cocaine abuse, Chagas disease, doxorubicin, and then of course these are easy ones to remember with the ABCD stuff. What people don't tend to remember is the hemochromatosis, sarcoidosis, and one that I've seen a lot on your NBMEs are the peripartum cardiomyopathy, right? Where a patient with, when you have pregnancy, there's more blood. So a patient that's pregnant could have dilated cardiomyopathy. And at that point, dilated cardiomyopathy, theoretically speaking, is always pathological. But in these people, you don't really have to do anything to treat it. It's actually a pathological thing, but a physiologic adaptation in pregnancy in a sense. So you don't treat it for them. But you have to realize that they're getting dilated cardiomyopathy is simply because they're pregnant. That's it. Alright, so these are things you have to make sure you understand. Got to remember how to do that. I have these silly little mnemonics I made up if it helps. But use whatever you got to use to remember this. Just make sure you have that down, because they're going to put that in questions, or it's going to be an answer choice, like picking eccentric hypertrophy instead of putting dilated cardiomyopathy. So that goes hand in hand. Dilated cardiomyopathy is equal to eccentric hypertrophy. You put them together. Alright, so coming back to here, things we care about, again, diagnosis, echo. Right, pretty straightforward. Remember I said that at the end of this chapter in your book, I put a summary of things. Right, so I put that for these guys too. Summary of things, how to diagnose, what to do. Right, so just do echo. Echo, echo, echo. Generally speaking, for the heart, most things you're going to be looking at, you would just do an echo, because you can actually see and visualize the heart at that point. Right, so echo is diagnostic. Chest x-ray would show a balloon-like heart in dilated cardiomyopathy, where you dilated the hearts with eccentric hypertrophy to stretch out the sarcomeres so that more blood can fit in there. Not bad. So dilated hypertrophic, which is the opposite, right? So you're going to see the hypertrophic cardiomyopathy is basically going to be the one where you circularly or concentrically added more sarcomeres to make it more muscular. And same thing, best initial test, just order an echo. As soon as you read a question and you realize that the patient is having either systolic or diastolic heart failure, or they're going to have some kind of cardiomyopathy, you should be pretty confident in picking that it's going to be resolved with diagnosed with a echo. Right? So as soon as you do the echo, you can see it. ECG may be normal or show signs of left ventricular hypertrophy. That's not good enough. Chest x-ray may reveal left atrial enlargement, secondary to mitral regurgitation. Okay, so these are all things that you're going to see and are relevant to the various things we've been talking about so far. Restrictive cardiomyopathy, not so high yield. You don't really see this too much. So back here, in fact, look at how thin this was. In first aid step 1, they barely talk about it. In fact, all they really do is list it out for you. Okay, so restrictive and infiltrated cardiomyopathy, they go together, and they're just cardiomyopathies that are related to things that are actually practically attacking or living in the heart now, even though they shouldn't be there. Okay, so you're going to be able to catch that pretty easily. Even in CK, all they really do is list it out for you. And they again tell you diagnosis is just going to be by echo, where you're going to see rapid early filling and a nearly normal or elevated ejection fraction. You're going to see things that look pretty similar to diastolic, but then you're going to know that it's not diastolic heart failure because they don't have any of the ABCD problems, nothing, right? So if you get to practice some questions on it, that'll definitely help you. But other than that, there's not much that can really help you pick this as an answer choice, unless they mention one of the things that are being listed out, right? If they mention any of these things, too many eosinophils, too much vibration, too much radiation going on. So this post-radiation fibrosis actually happens. Think of a scenario where a patient might come in for breast cancer, and you keep doing radiation to treat their breast cancer, and then that can lead to restrictive cardiomyopathy because of fibrosis that might happen on the heart from the same radiation. Right, so that's generally it for that topic as well. Then again, coronary artery disease, also pretty straightforward. So here is where you see your angina pectoris. Right, so angina pectoris is your substernal chest pain secondary to myocardial ischemia. Right, so this is a chest pain someone with MI has, and it's most likely due to obstruction of your coronary arteries. If your coronary artery has more than 70% blockade, blood flow isn't going to be good in there, and your own heart is not getting enough blood. Okay, so in this case scenario, you're going to have that chest pain that will require immediate treatment. Right, so best initial test for this person is ECG. In fact, ECG is what you order any time you have a patient come in for chest pain. If you have a patient that came in for chest pain, you order an ECG. However, there have been questions, right? So again, it comes down to picking the best answer choice. There have been questions where ECG wasn't even an answer choice because everyone remembers that, everyone knows that, right? By the time you're ready for CK, you will know that, like, secondhand knowledge, that if you have chest pain, you order ECG. So they don't even put that as an answer choice. So then at that point, you realize you're just going to look for stress testing and you're done. But the stress testing is a very high yield topic because look at how big this paragraph is. There's many ways to do a stress test. You could do a pharmacologic stress test. You could do a stress test on the treadmill. And all this really depends on how mobile the patient is. If the patient can't walk, you can't do a mobile stress test. And pharmacologic stress test is almost always perfectly easy to do because as soon as you do it, the coronary steal syndrome kicks in, and then they're going to have a little bit of chest pain, which quickly goes away because it's a short-lived effect. All right. And once you know that they have this chest pain because they had an MI, well, if anyone has an MI ever, you send them to the cath lab and you do an angiography to see which artery is blocked. Maybe it's the RCA, maybe it's the LCA, maybe the LAD, right, or PDA. Any of these, you see what's blocked, and then you can go ahead and clear it out, put in some stents, and the patient's good to go. All right, so this is called stable angina. All right, so this topic is discussed here as chronic stable angina or stable angina in general, which is your angina pectoris, chest pain secondary to myocardial ischemia, which is usually due to more oxygen supply and demand. Okay, more oxygen supply. Sorry, not enough oxygen supply, but more demand. Right, so as soon as demand is not being met, you get chest pain. The oxygen supply would be low because there's not enough opening to actually deliver it during the atheroma, right? The 70% blockade I was talking about. Now, you do have to clinically be able to differentiate stable angina with some of these things, right? GERD, acid reflux. A lot of patients will, no patient will literally come up to you and be like, hey, I think I have gastroesophageal reflux disease. That's not what most people will say. Most people will come and say, I think I have some acid coming back up, or I have some acidity, or I have heartburn, right? These are the more common terminology that everyday individuals will use. But there can also be some people who feel their heartburn as chest pain, and then they come and describe it to you as chest pain. But they'll probably say something like, oh, I have chest pain after eating. And at that point, you as a doctor will realize that that chest pain after eating is not chest pain, it's actually the GERD that they're having, and they just need omeprazole and they'll be okay. It could also be due to costochondritis. This is something that's really easy to diagnose because you simply palpate different parts of their ribs, and they'll tell you they feel pain. Then you know it's not chest pain. This is actually pain because they have inflammation of either the muscle or the bone and other things in their ribs, right? It could be pneumonia or pleuritis. So this is pain described as worsening with breathing and is often accompanied by fever and productive cough, of course, right? If you have pneumonia, you're going to have fever. It's an infection. And then, of course, if a patient has panic attack, right? Panic attack is one of the hardest things to diagnose in the emergency room because most people with a panic attack will present with symptoms of everything. They're going to have, people who get panic attacks can have very racing heart, they can have very high blood pressure, they can have an arrhythmia, they can have GI disorders. People can have panic attacks where they end up feeling really like they have diarrhea or something. So there's many different ways it can present, and it's so hard to actually pinpoint what the key problem is in a person who's undergoing actively a panic attack, right? So these are things you have to rule out when a person comes in and says to you, I have chest pain. When step 2 CS was a thing, this was tested by seeing what your response is, right? So if a patient tells you, hey, I have chest pain, what should your response be? And your response should be that you ask them, when does it happen, right? When do they get chest pain? And if they say it's every time they try walking or running or any kind of activity, then you know, yes, it's definitely just chest pain and it's related to the heart. If they say anything else, then it's not chest pain. Prince-Middle or variant angina, this is just vasospasm of the coronary vessels. So this is not due to atheroma. This is not a person who needs statins or something. They actually just need calcium channel blockers. Right? They need calcium channel blockers because they have vasospasm, and calcium channel blockers will help take care of that. Aspirin is actually avoided as it can aggravate the ischemic attacks. And what often happens in the real world is people get this chest pain and they go take aspirin because everyone loves being their own best doctor. And when they go take the aspirin, they worsen this shit, and then they come into the emergency room. So you have to see that. And when a person comes in, this is why we always ask them, did you take anything? Did you take anything to try to help yourself? And they'll tell you, yeah, I took Tylenol, ibuprofen, aspirin, whatever. Based off of that, you can figure out more things, right? In fact, for this case scenario, beta blockers are contraindicated because these beta blockers can further worsen the vasospasm, making them have even more angina, right? So only aspirin and beta blockers have been shown to have mortality benefit in the treatment of angina, but not variant angina. Okay, not for these people. And if you ever get a question where they're asking you what medication can you give to have a better mortality, then you have to pick between these two. So this is a tricky question. You're going to get a question about a patient who has heart failure, just had an MI, has angina or something, and then they're going to ask you what medication can you give for their to increase their mortality and or to have a benefit in their mortality, and they're going to have answer choices that actually are all medications that help with the chest pain. All the medications are going to be helpful for chest pain, but only one of those answer choices are going to be something that are a benefit to the mortality. Right? And it's going to be either the aspirin or whatever beta blocker they chose for that question. So what you're not seeing here, right? We saw the stable angina, we saw the variant angina. What we don't see here is unstable angina, because unstable angina does not fall under coronary artery disease. Right? So we're going to see that later on. Unstable angina is going to show up after this topic of shock as one of the acute coronary syndromes. Okay, so this differentiation between stable versus unstable angina is not actually really taught in step 1. Right? And it should be. It should be there. It should be differentiated very evidently, but it really isn't. Right? So unstable angina, which has no ST segment elevation, right? So it could be an ST depression MI. This unstable angina is actually an acute coronary syndrome, and we'll come back to this in a bit. What I want to do now is jump over to this page I added here to break down shock. Okay, this is a huge topic. You're going to get questions where they'll sneakily tell you something that happened to the patient's blood pressure, how their skin feels, etc., etc. They might even tell you the cardiac index, and then you have to figure out the fact that the person is undergoing some kind of shock. Right? So in there, for example, if you look at this question right here, 60-year-old man undergoes a right lung biopsy for diagnosis of restrictive lung disease. Okay, so restrictive lung disease is one of the things that are, there's a whole list of restrictive lung diseases like pulmonary fibrosis. It's not one of the obstructive lung diseases like COPD or stuff. 2 hours after the procedure, he develops severe shortness of breath and chest pain. His other medical problems include hypertension, hyperlipidemia, pernicious anemia, and an inguinal hernia repair 10 years ago. He doesn't smoke and he drinks sometimes. Now look at this. Blood pressure is very low, pulse is super high, respiratory rate is 30, and he is diaphoretic. The skin is cold and clammy. Everything they gave you here is describing shock. But you have to catch that his blood pressure fell, his heart rate went up, and his skin is cold. Pupils are equal and reactive to light bilaterally. Intra-arterial blood pressure monitoring is established, and pulmonary artery catheterization is performed. So again, if they ever do a catheterization in the question, you know something must have been problematic. But here they're doing mainly a PCWP investigation. So they tell you that his cardiac index is 2.3. Normal is basically between 3 to 4. I just remember it as 3 to 4. The specifics are 2.8 to 4.2, but those are more difficult numbers to keep in mind. So just remember, cardiac index needs to be between 3 to 4. And PCWP is 26 for this guy, which is definitely high, because the upper limit of that is supposed to be about 10 to 12. Your PCWP is based off of mitral valve pressure, and that's something that's actually been taught to you forever in your step 1 exam. When you looked at this graph right here, zoom in. So if you look at this graph right here, this pressure of the left atrial pressure line, right, which is about the mitral valve, this pressure is right here, around 10 to 12. It doesn't go any much higher than that. Okay, so that's what your PCWP is about. Looking at all of that, then they ask you what is the most likely diagnosis. Okay, the answer was just to pick MI. 40% got it right, but 24% of people chose tension pneumothorax, 15% of people chose pulmonary embolism, and 10% chose pulmonary parenchymal hemorrhage. And you really start wondering why some of these people would pick any of these other answer choices, because it's pretty clear he has an MI. But obviously it's not that obvious, because only 40% of people got it correct. Right, so now you have to learn, when you're studying these kinds of things and you see a question where only 40% of people got a question right, you want to figure out what it must have been that was going on in the mind of those people that picked the other answer choices. Because then you want to avoid that mental path, right? You don't want to fall into thinking the same way they did. And it's very easy to fall into some of these other paths and then picking the same answer choice as they did, because then you'll end up as one of the 24% of people that chose the wrong answer choice. So when you look at the explanation, try to figure out, what it is you were supposed to really focus on here to get that correct. For example, in my opinion, there was no way this was a tension pneumothorax, because in pneumothorax, there's going to be more evaluation in the question of the lung rather than everything I underlined. Right? We're still really only looking at heart things from everything I've underlined for the question. If a person has a pneumothorax, you would be evaluating their lung. You would try to see if there's lung sounds or not. You would try to maybe put an X-ray to see if the trachea has diverted at all. So stuff like that. It makes no sense. In fact, this guy literally just went through a right lung biopsy, and that's the only reason some people would think it's a tension pneumothorax. That maybe during the right lung biopsy, something went wrong. But nowhere in the question do they tell you that there's decreased air or decreased breathing sound or anything like that on the right side. Right? There's nothing given for you to pick that. I also don't understand why you would pick pulmonary embolism, because there was nothing given. Again, pulmonary embolism would be something that would go to one lung on either side, and the question would have to talk about things that occurred on that one lung. Right, so there was no reason for you to be one of the 39% of people that picked those choices, and then I don't know where pulmonary parenchymal hemorrhage came from. So whatever they were thinking, make sure you figure it out. Just don't think the same way. Okay. So this is what this table is for, and then I put these diagrams here, right? And this is all in your book. This is all diagrams from UWorld. On your book to be able to figure out exactly what kind of shock someone must be going into and why, simply by looking at things that are being given to you in the question. Okay, for our guy, this guy who has all this low blood pressure, high pulse, cold and clammy, all of that, they give you a cardiac index is decreased, right, and then PCWP is high. All of that information together, you should be able to figure out that he just straight up has cardiogenic shock, which makes sense because it's actually due to his heart that the problem is there, so it's a cardiogenic type of shock. Right? And you have to know everything in this table. It's not a table you memorize, it's a table you sit down and understand. Right? Why is this shit happening the way it is? Once you start seeing that, then you start understanding it. Take your time to make sure you go through this stuff. And then in the next video, we'll wrap up dyslipidemia and all of these things. I'm most likely going to make a video for you guys over the weekend myself when I have some time and just post it into the playlist so you guys can check it out and we can get through this quicker and cover more things in this month. Thanks a lot for joining, and I'll see you guys again next time. Boom, nigga.
Yo, you didn't hang up.